taken in a better way on a live session where I can show you the instruments and the procedure, how you conduct the normal instrumental deliveries, and what are the obstetrical operative procedures. But as you know, the situation, we just cannot talk each other directly. So I'm letting you know, and in case of anything which you could not be able to understand online, you can see me in the ward whenever you come back to the university. Okay, we are going to the operative obstetrical procedures, and at the end of the lecture, you must be able to know what is the operative obstetrics, and you know the different type of the vaginal operations, and you must have an idea of what are the indications to apply these instruments for the vaginal deliveries. And after the indication, you must know the complications of the operative vaginal deliveries and how may you be able to handle that. And the abdominal operations, which include the lower segment cesarean section and the obstetrical hysterectomy. In operative deliveries, intrapartum procedures may be vaginal or abdominal. On vaginal instrumental delivery, may you be able to apply forceps, and you apply the vacuum. With the vacuum, you need to do an extractions, and the forceps, you need to do a delivery. And breech extractions is there when the patient comes in a labor, and you need to conduct a delivery in a fully patient. You know the procedure, how you are going to conduct that. And an abdominal procedure, this is in a cesarean section, which is a lower segment cesarean section. And sometimes patient goes into the severe postpartum hemorrhage, and may you be needing to take the uterus out just to save the life of the patient. That is called the postpartum hysterectomy for the obstetrical reasons or the postpartum hemorrhage. We just don't use the forceps that much now, but initially we were having an outlet forceps, low forceps, mid forceps, and high forceps. Sometimes the high forceps and the mid forceps was carrying a lot of complications for the lacerations and the trauma, bleeding, everything. So now really that is not in practice to conduct the delivery with that type of the forceps other than the outlet forceps when the head is visible at the level of the introitus, and you need to have that out and ease out the delivery by the application of the outlet forceps. Outlet forceps in operative vaginal delivery, when you are going to apply these, when the scalp of the baby is visible at the level of the introitus, and you can see the presenting part, scalp at the introitus, even without separating the labia, that is at the level of the introitus and bulging out through the labia. Fetal skull has reached at the pelvic floor. Sometimes the pelvic floor, may you feel the caput, but the true pelvis skull of the baby is not there. But you need to assess the fetal head and the skull bone, which reach at the pelvic floor. And the sagittal sutures in the antero-posterior diameter. The right occipito-anterior, right occipito-posterior, left occipito-anterior, or left occipito-posterior. This is the sagittal sutures presentation. Fetal head is at or on the perineum, and rotation of that head does not exceed the 45 degrees. Okay, now you need to widen apart the pelvic, the legs of the patient, and put a patient in lithotomy position just to see where the presenting part and what is the sagittal sutures. And fetal is at the perineum, then you can apply the outlet forceps. And the presenting part more than or equal to the +2 station. +2 means that is 2 centimeters below the axial spines, and you can see the fetal head easily even without aparting the labia. When you are going to apply the forceps, what are the indications for that? Uses of the forceps. like maternal or the fetal indications. Sometimes we ease out the mother. Sometimes you need to save the baby. In cases, sometimes you need to apply the forceps for the prophylactic purpose, and sometimes it may be elective. These are the forceps. Actually, this is now obsolete. Since forceps, and this is the long shaft and everything. This is the forceps with the knobs and everything. But usually, this can, after the popularity of the cesarean section to decrease the maternal complications, these type of the forceps are out of the practice now. Forceps delivery, any condition which is threatening the mother or the fetus is likely to be relieved by a delivery with the application of the forceps. In any of the vaginal instrumental delivery or obstetrical surgeries, you have to have an expertise in your hand. Unless you are not expert in that application of that particular instrument, you may hurt the patient, you may damage the baby or the nerves of the baby. So you must have a proper expert person in your hand who is going to apply that. Maternal indications like heart disease, patient cannot tolerate that much pain, and sometimes the pulmonary compromise or any injury, sometimes intrapartum infection, and the certain neurological conditions are there with which you need to help out mother, and mother is not able to push that baby down and she's totally exhausted. Now you need to take the baby out to relieve the pain and everything from your patient. Then you can apply the forceps delivery to help her out in the delivery. This is a maternal exhaustion. Mother is so tired she cannot push the baby down, and sometimes prolonged second stage of labor. Actually, this happens with the application of that epidural anesthesia. When you give an epidural, maternal exhaustion is there. Mother is not able to push that baby down, and sometimes may you be needing help of the instruments to deliver that baby, because the feeling of that pushing down is lost by giving an epidural anesthesia. So the instrumental delivery or operative vaginal delivery is more common in a patient with an epidural. What are the fetal indications? Prolapse of the umbilical cord. You need to expedite the delivery within minutes because of the umbilical cord prolapse. Baby may go into the fetal distress because of that obstruction of the blood flow from that part of the cord which is hanging down. And this is a premature separation of the placenta, which is called abruptio placenta, which may lead to the fetal distress. And you need to expedite the delivery by application of the forceps, and immediately you need to take the baby out. And that is non-reassuring fetal heart rate pattern. If the patient is fully dilated and the baby is not coming out, and you can see the babies at the level of the introitus, just you need to give an episiotomy and take the baby out if the CTG is non-reactive. And the fetal distress may be because of any of the cause, like the umbilical cord prolapse, like the premature separation, or any abnormal CTG pattern. All these are the indication of the fetal distress. For the safety of the baby, you need to take the baby out without waiting for the normal progress. And just keep this thing in mind till that time the head is visible at the level of the introitus, and the baby is just coming out. You need to ease it out by application of the forceps and take the baby out. Okay, and this is the prerequisites. These are some prerequisites for the application of any of the instruments like forceps or the vacuum delivery. Head must be engaged, that must be descended down, with which you can fix the forceps in a proper way if the head is visible at the level of the introitus. Presentation should be vertex or chin anterior. Posterior chin is an indication for the cesarean section. Anterior chin in the face presentation, you can apply the forceps for the delivery. And you must know the position of the head, and the cervix os is completely dilated, fully dilated. and the membranes are ruptured. And these all are the prerequisites, and no disproportion between the fetal head and the pelvis. It means the pelvis is adequate enough to deliver that baby, and that baby is not that much good size, which may lead to the shoulder dystocia. So these are the prerequisites. Number 1, 2, 3, 4, 5, 6. Head is engaged. And in this, you need to empty the bladder as well. Bladder should be empty, because if the bladder is not empty, that may cause the fistula or the damage. The rectum and the bladder should be empty before the application of your instruments. Head is engaged, presentation vertex. Position, you must know the position of the baby. Vertex is complete, cervix is completely dilated, and the membranes are ruptured. No disproportion between the head and pelvis. It means no cephalopelvic disproportion, or the CPD, before the application of the forceps. You need to exclude all the things, and these are the prerequisites for the application, in which the bladder should be empty and the rectum should be empty. But even after that, any of the instrumental delivery also carries the morbidity for the mother and the fetus, that may be maternal or the fetal, like an episiotomy or the lacerations. Even after the giving the episiotomy, the lacerations may occur, because these are the two blades which you are applying on the lateral wall, so between the lateral wall, vaginal wall, and the head of the baby. When you are giving a traction and pulling that down, that may cause a laceration in the lateral vaginal walls. And sometimes the urinary or the rectal fistula, sometimes may patient run with the temperature or the infection. And in a baby, may you have having a low Apgar score and the cephal hematoma, and sometime that is maybe the caput formation trauma, which is high bilirubin, and the retinal hemorrhage in your baby. Okay, these are the complications of your forceps vaginal delivery. So everybody who is going to apply the forceps, they must know the patient may go into the postpartum hemorrhage because of that laceration or the episiotomy extension, or may she develop the infection or peripheral sepsis. So by keeping all the things in mind, you need to be very vigilant for your patient's post-operative or the post-delivery care. Some says baby may develop a cerebral palsy or the low IQ in a long-term morbidity, but that happens because of that instrumental delivery and the compression of some of the nerves while doing this procedure. So in summary, forceps delivery when performed inappropriately can result in a maternal and fetal adverse effect. So we have to have a proper expert hands which know the when to apply and how much traction, in what direction traction can be given, and how many times you need to apply, not more than 3, and gentle traction downward, forward, and upward with the anatomy of that genital tract. You need to give that traction in that manner, which can reduce the morbidities. And outlet and low forceps operations 45° or less can safely be performed if the basic guidelines are made and the patient and the consultant is expert enough for the application of that instrument, and that can anticipate the complication and treat them accordingly. And the trial of the forceps. Operative attempts of the delivery with the full knowledge and that the vaginal delivery may not be successful if the operator is not expert enough for that, and that person is not knowing how to give a pressure and what is the direction of that pressure. And if you are going to apply one blade and the other blade on the right side and on the left side, and you're going to lock these two blades, and now you're giving a traction to that baby. If the application of that blades are not appropriate and you're not going to fix them up, it means the baby's position is not normal. So don't force and don't try to apply it repeatedly. Better to do a cesarean section or do a delivery with a vacuum extraction rather than application of that forceps. So you should be expert enough to diagnose within no time, just to save the life of the baby. you need to know, okay, the application of the forceps would be how much successful in that patient. Okay. And the success of the application, the gentle pulse made but no descent is achieved, then you need to obsolete the procedure. This is a failed forceps. If you have applied the forceps, it is successfully closed and you're giving a gentle pulse, but no descent of the baby occurs, then it means that is something wrong with that baby. So you need not to force to pull that baby out. The procedure is then abandoned and the cesarean section is performed. So that is very important. You need not to force and to manipulate that much for the extraction of that baby. This is an operative vaginal delivery, which includes a breech. We are having a breech delivery. Sometimes the indication for the breech is a total, this is a normal delivery for the breech carries in complications for the mother and the baby as well. So we have to counsel the patient for the cesarean section. But sometimes you receive the patient with a full dilatation and she's a multigravida. You must know the steps how you are going to deliver that baby. Okay. In a breech, we are having a frank breech, and we are having a complete breech, and we are having an incomplete breech. In a frank breech, the lower extremities are flexed at the hip and extended at the knee. Look at this. This is a frank breech. Flexed at the hip and extended at the knee. Extended at the knee and flexed at the hip. This is a frank breech. And other is complete. One or both knees are flexed. Hip flex, knee flex, hip flex, knee flex. That is a complete breech. Okay. And incomplete, one or both hips are not flexed. One or both feet or knees lies below the breech. This, look at this. Sometimes this is flexed and this is extended, and this knee is flexed and this hip is flexed, and this foot is coming out of the introitus. That is a footling or incomplete breech. Okay. These both are the flex. And this is the flex, and this is flex. This is extended, frank breech, complete breech, and incomplete. How you are going to deliver a breech baby? That is a spontaneous breech delivery, which is called hands-off delivery. You are not supposed to do an intervention unless the breech or buttocks of the baby are visible at the introitus. And this is a breech extraction and assisted breech delivery. Okay, you need to wait till the baby's buttocks are visible at the level of the introitus. This is a Pinard maneuver. These are the feet of the baby, and the buttocks are visible at the level of the introitus. And you need to deliver a foot into the vagina. 2 fingers are carried along the extremities of the knee. Look at these 2 fingers, and this is a knee. You need to extend the leg at the knee and the hip joint. Push it away from the midline. Spontaneous flexion follows, and you need to deliver 1 leg. In the same way, you need to rotate the baby. This is a pulling the leg down. You need to rotate the baby, and you need to deliver the other leg in a Pinard method, where you are doing a flexion at the knee and extension at the hip, and you need to deliver the legs. And both of the legs are delivered. This is a sacrum, which is a sacro-anterior position. Let the baby hang down and wait for the next contraction. This is the body of the baby. You are whoever the delivering the baby is keeping the body of the baby on the left hand, and the right hand is at the shoulders. And you need to flex the head and deliver the baby. And this is a Mauritius simile wheat manure, where the back of the baby is anterior. You need to extend that back on the abdomen of the baby, mother. By doing this extension, you need to deliver, and otherwise you need to keep your middle and index finger applied over the maxilla. This is the maxilla, and this is your hand. You are applying this on the maxilla, and 1 finger in the jaw of the baby. By doing this, you need to force it and flex And this is with this hand, you are putting a gentle flexion pressure on the head. And now the baby's head is flexed and you can deliver the head of the baby easily. The foot is delivered by a Pinard method, and the body is next contraction, the body is delivered, and you need to take care of the umbilical cord only, okay? After that, this is another method, which is a peregrine maneuver, in which the back is posterior. So you need to put the, grasp the shoulders with your hand, and you need to pull the baby down. These are the Piper forceps. You are picking the baby up, and from the below you are applying these forceps. These are the methods to deliver the head of the baby. Now you have applied the forceps at the ear, right side and the left side. Now you're giving a gentle pressure on the forceps, and the other assistant is pulling the baby up. In this way, you can deliver the head of the baby. But always there are the risks for the mother, like maternal infection, uterine rupture, sometimes cervical lacerations, sometimes the extension of the episiotomy, and deep perineal tears, postpartum hemorrhage from the uterine relaxation. So all you may anticipate these complications, and you'll be able to treat all the things. But taking the baby out is not the end of the game. You need to sort it out if the maternal is having any infection, rupture, laceration, or any other problem. You need to see and deal it accordingly. Okay. These are the fetal risks. You may traumatize by pulling the legs down, by holding the abdomen, sometimes liver damage, sometimes the soft tissue trauma, sometimes the fractures of the leg, sometimes cord prolapse, and the fractures of the humerus and the clavicle, separation of the epiphyseal of the scapula, humerus, or the femur, paralysis of the arm, spontaneous spoon depressions or the skull fractures, and the broken fetal neck. Sometimes by holding the legs, may you cause a testicular injury. So your hands should be soft while you are holding your baby in your hands, and try not to pull with the pressure. Just give us gentle support, and wrap a baby in a cloth or in a softer things, which direct hands will not be able to traumatize your baby. Okay. These are the trauma. Whenever you are delivering a baby with a forceps or the vacuum delivery, you need to sort it out after the delivering for the fractures or the trauma, and you need to take a proper neonatologist opinion for that baby, and sometimes you need to a proper follow-up for a few months for the reflexes and the development of that baby. This is a vacuum extraction. Vacuum is a soft, gentle cup which you need to apply on the head of the baby with giving a machine pressure that can create a vacuum, and by pressure that you can pull the baby out. That is comparatively safer in a baby than forceps, because the forceps can occupy the lateral vaginal walls. By dragging that, you can traumatize the lateral vaginal walls, and which can cause the lacerations and the trauma. But the vacuum is applied just on the head of the baby, and by the head you can pull it down, so that can give a auto rotation, which is a natural rotation, and there is no extra occupation of that lateral vaginal walls. So that is a comparatively safer method for the delivery of the baby. But that is an artificial capet by attaching a traction device by the suction to the fetal scalp. Indication and the prerequisites are the same as we have seen into the forceps delivery, like cervix is fully dilated, head is engaged, patient lithotomy position, level is at the introitus, bladder should be empty, rectum should be empty, membrane should be rupture. All are the same indications and the prerequisites for the vacuum extractions. This is the vacuum cup. You can see we are applying it here, and we are giving a gentle pressure. No intervention of the lateral vaginal walls. This is a capet which can just pull the baby's head down. This is the center of the cup should be over the sagittal suture. This is the sagittal suture. and this is the posterior frontal. And this is 3 centimeter anterior to the posterior frontal. This is the location where you can apply the forceps. Vacuum can give a gentle traction, and that can cause the delivery of the baby easily. This is at the center of the cup, which is over the cerebral sutures, or 3 centimeter in front of 3 centimeter in front of the posterior frontal. Posterior frontal, and this is 3 centimeter anterior. You have applied the cup here, and with this attachment of the tube, you are giving a pressure with the pressure machine. We are having a suction machine attached, which is create a vacuum and the suction with which you can create a certain pressure and to deliver pull the baby down. Okay. And this is the same thing. You are not supposed to give traction more than 3 times, and you're not supposed to apply the forceps if the vacuum is failed, and you're not supposed to apply the vacuum if the forceps are failed. So 3 times you can apply, and if the baby is not descending down, then you have to have a cesarean section. This is an abdominal operation. This is called a cesarean section. And this is the delivery of a baby by abdominal incision. And if you are giving an incision in the abdominal wall, that is called a laparotomy. And in the uterine wall, that is an hysterotomy. Abdominal operation or a cesarean delivery. What are the indications? If the patient is having repeat cesarean section, like previous 1 cesarean, previous 2, in a 1 cesarean section, you can give a trial of labor if there is no any other contraindication for the vaginal delivery. But if the patient is having a 2 or 3 cesarean section, all the time you have to have a cesarean section. After 2 cesarean section, the normal delivery is not possible. And what you call a normal delivery after a cesarean section, that is VBAC, vaginal birth after cesarean section. After 1 cesarean section, you can give a trial for the VBAC, but not after 2 cesarean sections. And this is the indications like repeat cesarean section, and sometimes the dystocia or the failure of the progress in the labor. You are making a partogram, and according to the partogram, patient is having a good uterine contraction, but the labor is not progressing, baby is not descending down. Then you need to do a cesarean section. Sometimes the baby is in a breech presentation, the presenting part is very high, and the pelvis is not adequate. You have to have a elective cesarean section, because breech normal delivery carries somehow other more complications than a breech cesarean section, and those perform out of the concern for the fetal well-being. Sometimes the baby is very precious for the family, sometimes because of the ovulation induction, sometimes the maternal age is that much, sometimes any of the other maternal wish to deliver that baby by cesarean section for the well-being. So always you need to deliver the baby by doing an abdominal route. An abdominal incision may be given in vertical. Like this is the uterus, and you are giving this type of the incision. This is a longitudinal, the vertical incision, which is quickest to make the greater chance of the dehiscence, which is quicker to deliver. Sometimes the maternal cardiac arrest is there, and you are doing a CPR. You need to take the baby out in an emergency just to do a proper CPR to your patient. Sometimes trauma accident, so you need to go quick and deliver the baby. So that is a vertical incision in the abdominal wall, which can be given for the quicker delivery of that baby. But that incision carries post-operative greater chance of the dehiscence or the rupture. Okay. And this is a financial incision, which is a normal transverse incision, which is given in the abdominal wall, in the lower crease of the abdominal wall. And the cosmetically it is better and is stronger, less chance of the dehiscence, and exposure is not as much as there in the vertical incision, because that is it's a low-lying incision which can be covered properly, which is not a prominent incision in the abdominal wall. These are the abdominal incisions. And in the uterine incisions, while opening the abdominal wall, you are giving a vertical incision on the uterus. This is a vertical. Vertical is a longitudinal incision giving to the body of the uterus. If the lower segment is not exposed, transverse lie of the baby, placenta previa anteriorly located, and the lower segment is not formed. But that is not truly required, I'm telling you. All the time the segment, lower segment is formed, and that is better to give the low-lying incision. Other than the saving the maternal life, sometimes you need to do a CPR and the mother is dying. You need to take the baby out immediately. Then you need to give a classical incision. Lower segment transverse incision. This is then on the uterus. Look at this. This is the longitudinal, this is the uterus. And if you are giving in classical incision, that is a longitudinal incision to cut the uterus. And this is the transverse diameter, the financial diameter, which is a low line. This is a good in the healing and the recovery and everything. But this is an urgent when you are delivering the baby in a condition, if the mother is died, God forbid, and you need to take a baby with no time. So this is the best incision to go through and take the live baby out. Location in the site at least likely to rupture in the subsequent lower segment transfers is easier to repair, and it does not promote the adhesions of that bowels and momentum to the incision line if you are giving a low line. But that is a site of the rupture in the next pregnancy. Because of that, that is less in the musculature. The healing is that it cannot tolerate the labor pains in a second pregnancy. So you have to have a cesarean section at 38 weeks of the pregnancy. And if patient goes into the labor, you need to be very vigilant for the thickness of that scar, how much that is thin or thick. Can that tolerate the labor? If you are giving a trial of labor with a previous one cesarean section, the thickness of the scar is very important. These are the type of the incisions. And some postpartum hysterectomy. This is an indication like the patient went into the PPH and patient developed in a relaxed uterus. Sometimes for the saving of the life of the patient, you need to take the uterus out. You have to done all the methods to hamper that bleeding, but still the patient is bleeding and the uterus is relaxed, and you have taken a decision to take the uterus out to save the life of the patient. These are sometimes the patient is having a severe intrauterine infections, puerperal sepsis, and the uterus is so much infected, you just cannot leave the uterus in. That may be the site of the infection, you need to take that out. Sometimes grossly defective scar, mark hypotonic uterus. Hypotonic means his uterus is not well contracted and not well contracted and is bleeding, relaxed uterus. That can take the life of the patient. So just to save the life of the mother, you need to take the uterus out. And if she has completed the family. Lacerations of the major vessels, large myoma like the fibroids, severe cervical dysplasia, and carcinoma in situ, the placenta previa or accreta. Sometimes these are the indications to take the uterus out. And a postpartum hysterectomy, major like a cesarean section, deterrence is increased blood loss and the urinary tract damage. Bladder is so much attached with that uterus, and because of the previous cesarean section, sometimes the bladder is higher up. It's difficult to take the bladder out of that level of the incision. So accidentally may bladder rupture, and may you be needing help of the urologist, and the bowel and the gut is adherent to the uterus because of the sepsis. So you have to have a proper consultants with you for the surgery, for the urology. Sometimes the patient is bleeding so much in cases of the accreta, may you be needing an internal iliac vessels ligations. So that is a teamwork which you need to anticipate and call them up all the time just to save the life of the patient. So many maternal complications can be avoided by having all the surgeons on the board at the same time. The morbidity increase of the cesarean hysterectomy is done on an emergency basis. That is because all the time, all the persons are not available everywhere. We are working at a tertiary care center where all the surgeons and everything is available with no time, but that is not happening everywhere. So you need to anticipate all the complications, and it's better to refer the patient to a tertiary care center with all facilities available. And if you are doing this procedure in an elective list, so you need to give a call to your urologist, your surgeon, your vascular surgeons, and call them up with the availability of the senior obstetrician to take a proper and timely decision to save the life of your patient. And what are the abdominal operations for the postpartum hysterectomy like techniques? Sometimes you need to take total hysterectomy, total uterus is taken out. And we are having 2 ovarian tissues on the ovaries on the sides of the uterus, and the ovaries are normal, healthy. You are not supposed to take the uterus out. You're not supposed to take the ovaries out in a young patient. You need to do a total hysterectomy. Total hysterectomy means taking out the uterus with the cervix. In that procedure, may you be needing more extensive mobilization of the bladder, medially and laterally. It is necessary because the cervix is exactly behind the bladder, while the mobilization of that bladder, when you are descending the bladder down, and you can see the cervix easily, and you need to take the uterus out. This is called a total hysterectomy. And sometimes if the total hysterectomy is not possible because of the adhesions, or sometimes the patient is bleeding so much, you need to do a subtotal hysterectomy, which is the amputation of the body of the uterus. You need to take the uterus out above the level of the cervix, and you are leaving the cervix behind. But it can always carry a risk of the bleeding even after the hysterectomy. So that is the cervical portion which is left behind, that can cause the bleeding, and the chances of the CA cervix are always there. And so you need to take the risk and the benefits simultaneously, and you need to take a decision to leave the cervix in if it is not possible to take the cervix out because of the adhesions or everything. So that type of the patients may be needing a proper post-operative follow for a longer time. Presentation of the fetus is altered artificially. In a breech presentation, sometimes you need to take a delivery of the breech baby by the Pinard method and the Mauritius simile meat manure by application of the forceps. If the patient had a previous normal deliveries, you can easily do a delivery of breech by doing an assisted breech delivery. Sometimes you have to have a proper elective cesarean section for that breech baby. And sometimes you need to do a version, that is its external cephalic version. External cephalic version in a baby in which the baby is in 37 weeks of the gestation, and you need to do a rotation of the baby and by pulling the buttocks up, and now you are gently rotating the baby and putting the baby's head down into the pelvis and the buttocks up. This is a substitute when the one pole of the longitudinal presentation for the other. Convert the oblique or the transverse. Transverse, like this is a transverse line. You are holding the baby and you are rotating the baby by two of your hands, and you are pulling the baby's head down and the buttocks up. By doing this, you need to do a CTG before the procedure. You need to do a CTG after the procedure, and with the availability of all the cesarean section instruments and everything with you, because that may cause a certain fetal distress and the entrapment of the cord and the distress of the baby on the CTG. You need to take the baby out by doing an emergency cesarean section. And sometimes if the baby is normal, CTG is reactive, you need to keep the patient for an observation for a few hours just to see the response of that external cephalic version. That is an external cephalic version because you are doing it externally above the abdomen at 37 weeks of the pregnancy. And you need to rotate the baby from the oblique transverse into the longitudinal presentation. And that is an external version. Manipulations are performed exclusively through the abdominal wall. Abdominal wall, you are not going inside. Doing an abdominal wall, and above the wall, you are holding the baby and try to rotate the baby to a cephalic presentation. This is the method. Look, this is the baby. This is a baby with a breech delivery. You have dislodged that breech by putting your hand, and with a gentle pressure, you are flexing the head of the baby, and now you are rotating it. Look at this. This is the arrow in which direction you are flexing. Gentle, 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 and in this way. Then you need to repeat the CTG. Then you need to do a gentle, gentle, gentle pressure by putting the head of the baby down. Now you need to reassess for the presentation by doing an ultrasound or by doing in CTG, just to see how much the baby is breathing properly, or if anything would happen, God forbid, then you need to do an emergency cesarean section. Okay. And this is an external cephalic version. In a breech presentation, in a shoulder presentation, there is a no marked CPD or no placenta previa. If there is any other indication for the cesarean section, then what is the fun of doing these procedures? If the patient have previous normal deliveries, then you can go for it. If there is no any other contraindication for the cesarean section, if there is no any other contraindication for the normal vaginal delivery, like a previous cesarean section or inadequate pelvis or the cephalopelvic disproportion, in these cases, there is no fun of doing these versions. If it is all the contraindications for the vaginal delivery are excluded, then you need to do a external cephalic version where there is no any CPD or no placenta previa. So these are the all basic prerequisites. You need to sort it out. Would she be able to deliver vaginally even after doing like an external cephalic version? How much your patient is willing for that and how much is she cooperative? But the risk for the maternal mortality, placental abruption, uterine rupture, fetal-maternal hemorrhage, preterm labor, always that is there. But you need to do a term pregnancy just to avoid the preterm labor and fetal-maternal hemorrhage. You are having an ultrasound, and with the gentle pressure, this very slow, it may take time. You're not supposed to pressurize the uterus. Then you can prevent all these complications. Presenting part has not descended into the pelvis. If suppose that presenting part has gone down at that level of the pelvis, then it's very difficult to rotate the baby. So the presenting part should be above the brim. Then you can hold the presenting part and you can rotate the baby. Okay. And there is a normal amount of amniotic fluid. Because in a fluid, baby can move. If it is already hugged up with the uterus, that would be very difficult for you guys to move that baby. And that should also be done by an expert person. And fetal back is not posterior. Look at in the figure, the back of the baby is lateral. On that lateral wall, that is not posterior, like the back of the baby and the back of the mother. So the back of the baby should not be posterior. And the woman should not be that much obese. Obese abdominal wall, very flabby abdomen and the distended abdomen. So where would you not be able to hold the parts of the baby and you just cannot rotate it in a proper way. So better not to try in that type of the patients where the chances of the failure are always there. Internal podalic. If there's external podalic version, so there must be an internal podalic. So what is an internal podalic version? This is the baby which is delivered. One baby is in a twin pregnancy. One baby is delivered and the other baby is with a breech presentation. Then you need to grasp the feet of the baby and you need to pull the baby out. In a second twin, this is an internal podalic version where the os is fully dilated. One of the babies delivered. Now you need to expedite the delivery. You need to hold the baby and pull it down. That is the internal podalic version. Look at this. the baby's head is there, and now you are holding the baby's feet, grasping it and pulling it down, which can rotate the head of the baby and deliver the buttocks first, and then the baby's head would be coming. Because head sometimes may not be that engaged and you cannot pull the head of the baby. You need to hold the feet and now you can pull and deliver. This is an internal podelic version, which is only indicated in a baby with a twin delivery. Look at this. What is it in? This is a pressure. Head is applied on the downward traction is in the feet. You need to hold the feet and pull it down. Okay, guys. We're just going back. I hope everybody was there from the beginning. Just a minute. Lower segments, and this is a question, what do you mean by the lower segment is not formed? Sometimes the baby is in a breech presentation, the uterus is thick, lower part is thick and not formed, and sometimes you're doing a early pregnancy delivery because of any of the maternal complications like a previous cesarean section. Now the patient is having an eclamptic fit and the patient is 32 weeks of pregnancy. Then the lower segment is not properly formed. This means usually the lower segment form in a pregnancy of advanced gestational age. It's an internal podelic version performed in a complicated cases. No, that is not all the time. That is indicated only for the second baby who you need to expedite the delivery in a second baby where the foot os is fully dilated and you need to take the baby out with no time to avoid the complication called prolapse, fetal distress and everything. You need to hold the feet of the baby and pull it down. That is an internal podelic version. Okay. अच्छा यार पता नहीं क्या लिखा है आपने. और क्या क्वेश्चन है बताओ. Any other question? ये तो हो गया ना आपका. सही है. ये ऑपरेटिव प्रोसीजर्स हुए जिसमें हमने क्या किया. अब आपको पता चल गया है कि जो ऑपरेटिव ऑब्स्टेट्रिक्स क्या होती है. In operative obstetrics means you need to help some of the instrumental delivery, and that may be forceps delivery, that may be vacuum delivery, and that may be the breech extraction, and sometimes the lower segment cesarean section. Okay, and cesarean section है डिस्कस कर ली हमने. कॉम्प्लिकेशंस भी अब इसमें आपको ये पता चल गया इन सारी चीजों का कि जी आप हमारा नेक्स्ट ये था. हमने आउटलेट फॉरसेप्स लगाए थे. लो और मिड और जो हाई फॉरसेप्स है अब ऑब्सोलीट है, वो नहीं लगती. आउटलेट फॉरसेप्स आपको बता दिया कि आपको कब लगने. व्हेन द इंट्रोइटस पे आपको प्रेजेंटिंग पार्ट इज visible at the level of the introitus, station is +2, and all you need to know what are the maternal indications when you are expediting the delivery and the prerequisites, heart disease, any of the pulmonary complications and any other maternal exhaustion and prolonged second stage when you need to help the mother out to deliver the baby by a forceps or the vacuum. And sometimes the fetal indications are there in which you need to expedite the delivery. Head should be engaged, membrane should be ruptured, and the presenting part should be known to you. That is a vertex, os fully dilated, membrane rupture, bladder empty. And sometimes that may cause a complications in the mother and the baby. You need to know the complication. You may be able to anticipate and to deal with that also. This is the summary of the forceps delivery, and trial of the forceps should not be done more than 3 times. Traction should not be given 3 times, more than 3 times if the head is not coming down. This is called a failed forceps. You need to do a cesarean section. This is a breech which may be frank, complete or incomplete, and you need to do a spontaneous breech delivery, Pinard method for the delivery of the feet. This is a Mauritius maneuver for the delivery of the head. Sometimes may you be needing a forceps application for the delivery of the head of the baby, okay? And this is a vaginal maternal risk, same rupture, laceration, PPH, tear, and the postpartum hemorrhage. Fetal risk, fetal distress, trauma, fractures, that is always there in the manipulation because of soft bones in the skin, and everything is so soft of the baby that may be damaged by handling of that baby. And this is a vacuum which I'm going to apply the 3 centimeter anterior to the posterior frontal. You need to give a gentle traction to deliver that baby. And this is the cesarean section indications. This is the type of the abdominal incision, and this is the incision on the uterine wall. This is the lower segment cesarean section. This is a longitudinal or the transverse is called a financial incision, which is ideal for the delivery of the cesarean section baby. And this is the indications. And the major cesarean hysterectomy, deterrence से increased blood loss हो गया या urinary tract में damage है, you need to take the uterus out, morbidity increase हो जाती है अगर आपने cesarean कर लिया. टोटल hysterectomy है और अगर आपने cervix छोड़ दिया तो उसको सब टोटल कहेंगे. वर्जन्स में एक्सटर्नल केफेलिक वर्जन आएगी, इंटरनल केफेलिक वर्जन आएगी. एक्सटर्नल केफेलिक वर्जन हम ब्रीच में, ट्रांसवर्स में, शोल्डर में कर रहे होते हैं. और इंटरनल केफेलिक वर्जन यू आर डूइंग इन internal podalic version is a delivery of the second twin only. This is the only indication for the internal podalic version. Look at this, grasping the feet of the baby and pulling it down. Done? Hopefully it's done. I don't know how many of you are there, and if there is no chat question, it means to understand all the things, or may you not be there. Anyone type thank you if you are done with it? Okay. Good guys. Hope to see you in the ward, inshallah. And I'll show you the instruments and everything, whatever you want to see. Shortly, inshallah, you will be back and we'll see you soon directly. Okay. Thank you. Allah Hafiz.